Welcome to the podcast to preserve, protect, and defend the soul of America.
The topic we shall discuss in today's show, the opioid and fentanyl crisis.
I'm your host, Alex.
And I'm your co-host, Sam.
So I want you to just imagine for a second a single pharmacy in a tiny, tiny Appalachian town. The town is called Kermit, West Virginia.
Right.
And the population of this town is exactly 392 people. Like, that's it.
It's barely a blip on the map.
Exactly. Now, I want you to imagine a fleet of these massive delivery trucks just pulling up to that one small-town pharmacy, like week after week, month after month, just constantly unloading boxes.
Just endless boxes of pills.
Yeah, and over the course of just 2 years, those trucks deliver 9 million highly potent, highly addictive prescription painkillers.
It's hard to even wrap your head around that number.
9 million pills for 392 people. I mean, if you do the math, that is roughly 11,000 pills for every man, woman, and child in an entire town every single year.
Which, when you first hear that, it sounds like a clerical error. It sounds like a glitch in the matrix of our medical supply chain, like someone accidentally added a few extra zeros on an invoice.
But it wasn't an error. It was, unfortunately, a highly calculated, legally sanctioned business plan. And that's exactly what we're taking a really profound, comprehensive deep dive into today. We're looking at a crisis that has just fundamentally reshaped the American landscape over the last quarter century.
Absolutely. And if you look at the subtitle of our source material today, it reads, From Pharmaceutical Boardrooms to Street Overdoses.
And that geography is so important.
It really is. That journey from the polished mahogany tables of these corporate executives all the way down to the concrete sidewalks of our cities is the exact path we are going to trace for you today.
Because it is an incredibly vast landscape to traverse. Like, we are looking at a mass casualty event that is, well, it's entirely unique in modern history.
Yeah, and the statistics have just grown so monstrous over the last 2 decades that they risk becoming, just background noise.
I know what you mean. We get desensitized.
We do. Human beings just aren't psychologically equipped to process numbers this large. We go completely numb to them.
But we can't let these numbers become abstractions. Because, like, literally as we speak, somewhere in the United States, someone's child or parent or neighbor is dying of a drug overdose.
Yeah.
So let's just frame the sheer scale of this for you right up front.
Okay, let's hear the numbers.
In 2023, which was near the historic peak of this crisis, more than 107,000 Americans died of drug overdoses in a single 12-month period.
Just staggering.
And over 76,000 of those deaths involved synthetic opioids, which is primarily fentanyl. To give you some context on that scale, because I think context is everything here.
Right.
The United States lost roughly 58,000 soldiers over the entire multi-year course of the Vietnam War.
Wow.
So at its absolute worst, this overdose crisis was killing that many people every 7 months. I mean, it has killed more Americans since 1999 than World War II, Korea, and Vietnam combined.
But, here is where the narrative requires an immediate and, frankly, a rather stunning complication.
Yeah, this is the part that actually surprised me.
Because for the first time in a quarter century, after climbing year after year with this grim, almost mechanical inevitability, the death toll has actually begun to fall. And I mean, fall sharply.
Which is something you rarely hear about this topic.
Exactly. Provisional federal data shows deaths dropping from that 110,000 mark in 2023 down to about 80,000 in 2024, and then plunging to under 70,000 in 2025.
That's a massive drop.
It is. It's a decline of more than a third in just 2 years. It's literally the steepest reversal on record.
Which, I mean, that sounds like incredible news, right? And, of course, it is a relief. Every life saved is a relief. But as we explore the underlying mechanics for you today, you'll realize that 70,000 deaths a year is still just a catastrophic baseline.
Yeah, 70,000 is not a victory lap.
Not at all. It's the equivalent of a packed NFL stadium just vanishing every single year. So the mission for our deep dive today is to unpack exactly how this happened. Like, how did a cascading series of medical, regulatory, and corporate failures snowball into this mutating mass casualty event? And why, after all this time, are the numbers finally shifting?
Because you have to understand, this didn't start in a dark alley.
No?
It didn't start with what society so often likes to frame as, individual moral failings. It started with remarkable precision in pharmaceutical boardrooms, regulatory chambers, and incredibly prestigious medical schools.
Right. And to truly grasp the modern crisis, we actually need to pull the camera way, way back. Because humanity's relationship with opioids is not a new phenomenon at all.
Not even close.
What is new is the industrial scale and the synthetic manipulation of it. We actually have a 6,000-year documented history with the opium poppy.
Right, biologically known as Papaver somniferum.
Which literally translates to the sleep-bringing poppy, right?
Exactly. It's fascinating because archaeological evidence from the Neolithic period in Europe shows ancient peoples harvesting this exact plant.
And how did they do it back then?
They would score the seed pod with a blade, and it would bleed this milky latex. And when that latex dries, it becomes raw opium.
I was absolutely struck reading the source text by what the ancient Sumerians called it. They referred to it as whole gill, the joy plant.
The joy plant.
There is this refreshing, brutal honesty to that ancient name. It acknowledges the profound euphoric properties of the plant, an honesty that later centuries of Western medicine completely buried under all these sterile medical euphemisms.
That's so true. They knew exactly what it did.
We know the ancient Egyptians used it to quiet crying infants and to ease the agony of the dying. Even Hippocrates, the father of Western medicine, used it as a purge and a hypnotic.
And its medical prestige just kept growing throughout history. Look at Galen, the Roman physician. His authority absolutely dominated European medical thought for over 1,000 years.
And he didn't just use opium, right?
No, he championed it. He strongly advocated for it in these complex compound preparations. And the most famous of these was called theriac.
Theriac.
Yeah. Theriac wasn't just a medicine. It was marketed as the ultimate cure-all. It was the most prestigious, expensive, and sought-after pharmaceutical of the ancient and medieval world.
Like the ancient version of a miracle pill.
Exactly. It had dozens and dozens of ingredients. But the active engine that was driving its perceived miracle effects was always the opium.
And this supreme medical authority just persisted for centuries, long before anyone understood the underlying biological mechanics of addiction.
Precisely. Now, in the 11th century, you do have the Arab physician Avicenna, who noted both its powerful analgesic properties and the severe dangers of excessive use. So, he recognized the hook.
He saw the dark side of it.
He did. But when this medical knowledge transmitted back to Europe during the Renaissance, the Swiss physician Paracelsus took it a step further. In the 16th century, he created laudanum.
Oh, laudanum. I mean, you read literally any 19th century literature, and laudanum is just everywhere.
Right, it's ubiquitous. It was basically a tincture of opium dissolved in alcohol. The alcohol acted as a solvent and a preservative. And for the next 3 centuries, laudanum was the most widely used medicine in the entire Western world.
And you didn't even need a prescription, did you?
No, not at all. You could just buy it at the local apothecary. It was prescribed for literally everything. A bad cough, menstrual cramps, joint pain, and horrifyingly, by modern standards, for teething pain in infants.
Wow. Giving opium to a teething baby.
It was standard practice.
Okay, but this is where the history in the text takes a very dark turn for me, moving from this ancient medical reliance to just ruthless state-sponsored geopolitics.
Right, the economic side.
Yeah. When we look at the 18th and 19th centuries, you see the economic dimensions of this plant emerge in a way that feels eerily modern. I'm talking about the British East India Company.
Oh, yeah. This is a massive piece of the puzzle.
They essentially established opium cultivation in Bengal, and it became a central load-bearing pillar of the entire British Empire's economy.
I mean, let's call it what it was. It was a massive multinational drug-running operation. The British East India Company grew vast quantities of opium in India, and they sold it to China for massive, astronomical profits.
And they used that profit for what?
They used that silver to buy Chinese silk, porcelain, and tea to sell back in Britain. It was incredibly lucrative.
But the Chinese government eventually realized what was happening, right? That millions of their citizens were becoming hopelessly addicted. It was completely hollowing out their society and draining their silver reserves.
Yeah, it was an existential crisis for China.
So the emperor tried to ban the import and burn the stockpiles. And how did the British Empire respond? Did they respect the sovereign health laws of another nation?
Of course not.
No. They literally went to war. The Opium Wars in the mid-19th century were fought by Britain to force China to keep its borders open to British opium.
It is considered by historians as the purest example of a state utilizing overwhelming military force to enable the sale of a highly addictive drug to an unwilling population, purely to maintain a favorable trade balance.
It's literal state-sponsored cartel behavior.
It really is. There's no other way to describe it.
It's staggering to think about.
No.
But meanwhile, Back in Europe and America, the 19th century birthed the era of patent medicines.
The Wild West.
Completely. This was the Wild West of pharmacology. You had these entirely unregulated commercial concoctions sold directly to consumers in glass bottles with these colorful, beautiful labels.
And no oversight whatsoever.
Zero. There was no FDA. There was no requirement to list ingredients, let alone prove that this stuff was actually effective or safe. You had products like Mrs. Winslow's Soothing Syrup, which was marketed heavily to exhausted mothers to calm their fussy, teething babies.
And it worked miraculously well, of course.
Because it was absolutely packed with morphine.
Mothers were essentially heavily narcotizing their infants, entirely unaware of what they were actually administering. They just saw that the baby stopped crying.
And this complete lack of regulation led to one of the most infamous medical blunders in history. The text outlines how in 1898, the German pharmaceutical company Bayer, and yes, that is the exact same company that makes the aspirin sitting in your medicine cabinet today, introduced a brand new synthesized drug. They called it heroin.
Heroin with a capital H. It was a brand name.
And the way they marketed it is just mind-blowing to me. They didn't just sell it as a painkiller. They aggressively marketed heroin as a safe, non-addictive substitute for morphine.
The irony is just incredibly dark.
They literally sold it as a cough suppressant for children. For years, well-meaning doctors across the globe prescribed it, genuinely not understanding that they were mass-producing heroin addiction.
Because the underlying science of addiction was still so poorly understood, they focused entirely on the immediate observable effect. The cough stopped, the patient felt better.
Right, problem solved.
The long-term physiological rewiring just wasn't tracked or understood at all.
Which brings up a wild parallel for me. If you look at the blind, absolute faith that people had in those 19th century patent medicine salesmen, or the faith doctors had in Bayer's 1898 heroin brochures, how different is that really from the unquestioning faith we placed in FDA-approved pharmaceutical labels 100 years later?
That is a very sharp comparison.
Like, how did we pivot from literally giving heroin to children in 1898 to heavily criminalizing the medical condition of addiction just a few decades later?
Well, that pivot was entirely engineered by legal policy. It was not driven by a sudden advancement in medical empathy or understanding.
Okay, so what was the policy?
The Progressive Era's response to this chaotic, unregulated landscape of addicted citizens was the Harrison Narcotics Tax Act of 1914. This was America's first major federal drug law.
And what did it do exactly?
On paper, it was framed simply as a tax and record-keeping measure for doctors and pharmacists. Just bureaucratic paperwork. But through incredibly aggressive interpretation and enforcement by federal agents, it was used to prohibit physicians from prescribing opiates to patients to maintain their addiction.
Wait, pause for a second. So if you were, say, a housewife who got addicted to laudanum because your doctor told you to take it for cramps, what happened to you the day after this act was aggressively enforced?
You were cut off. Overnight. The Harrison Act transformed hundreds of thousands of legitimate medical patients into criminals. Doctors who tried to taper their patients or maintain them were raided and arrested.
That's terrifying.
And this exact moment is what birthed the modern illicit drug trade. When the legal medical supply vanished, the black market instantly materialized to fill the biological demand.
Because the demand didn't just go away. The addiction was still there.
Exactly. And that punitive criminal framework just hardened like concrete over the decades. You get the Marijuana Tax Act in 1937. You get the Narcotic Control Act in 1956, which introduced mandatory minimum sentences.
And then it culminates with Nixon, right?
Right. The culmination of this ideology is the Controlled Substances Act of 1970, signed by President Richard Nixon, who officially declared the war on drugs.
And the motivations behind that war were explicitly political, not medical. We have to look at the historical record here. The source material details this interview with John Ehrlichman, who was Nixon's domestic policy advisor.
It's an incredibly startling interview.
He admitted on the record that the Nixon White House had two main enemies, the anti-war left and black Americans. Ehrlichman confessed that the war on drugs was deliberately designed to target those two groups.
It was entirely weaponized policy.
By heavily associating hippies with marijuana and black communities with heroin, and then criminalizing both heavily, they could disrupt those communities. They could arrest their leaders, raid their homes, break up their meetings, and vilify them night after night on the evening news.
It's a quote that just echoes through history.
He literally said, "Did we know we were lying about the drugs? Of course we did."
Yeah.
It's chilling. But this history is so crucial for you to hear, because it reveals the deep structural incoherence at the very heart of American drug policy.
Ah, so.
We fiercely criminalize addiction when it appears in poor, minority, or politically marginalized communities. But simultaneously, as we'll see, we allow the corporate pharmaceutical industry to create addiction on a massive scale through legal, white-collar medical channels.
Yeah.
The moral geography of good drugs versus bad drugs has historically been based entirely on race, class, and who holds the patent, not on the actual pharmacological reality of the chemicals.
Exactly. And that dichotomy perfectly sets the stage for the massive medical paradigm shift that occurred in the late 20th century. Because for most of the 20th century, largely because of the chilling effect of the Harrison Act and a genuine healthy fear of addiction, doctors were incredibly cautious with opioids. They reserved them almost exclusively for acute trauma, like a massive car accident, post-surgical recovery, or end-of-life cancer care.
So what changed? How did we go from being terrified of these drugs, arresting doctors who prescribed them, to handing them out like candy for a sore back?
The shift actually began from a place of deep medical compassion. In the 1980s, pain management specialists and oncologists recognized a horrific reality. Terminally ill cancer patients were dying in unnecessary, agonizing pain.
Why? Because their doctors were terrified of turning them into addicts.
Exactly. Which, if you think about it logically, is an absurd and cruel concern for a dying patient. The risk of long-term addiction is essentially irrelevant if the patient only has 6 months to live.
Right. That initial advocacy was deeply humane and medically correct.
Yeah.
Nobody wants their grandmother dying in agony because a doctor is worried about dependency.
No, but
But this compassionate argument underwent two catastrophic fatal expansions. First, the push to treat end-of-life cancer pain mutated. It expanded to include chronic non-cancer pain. Suddenly, doctors were being told they should prescribe these powerful narcotics for everyday ailments: lower back pain, arthritis, fibromyalgia, sports injuries.
And the second expansion was the justification for this shift. Advocates, backed by pharmaceutical interests, started claiming that opioids were not only effective for this kind of long-term chronic pain, but that they were inherently safe.
That's the wild part.
They argued that if a patient had legitimate pain, their risk of developing an addiction was phenomenally low.
And this is where the story gets really interesting and, frankly, infuriating. You would assume a shift of this magnitude changing the prescribing habits of an entire nation's medical establishment would be based on massive, rigorous, double-blind, multi-year clinical trials, right?
You would assume so, yes. But the evidence base was shockingly flimsy. It is one of the greatest scientific cascading failures in modern history.
I couldn't believe this part of the text.
The pivotal piece of evidence was a letter published in the New England Journal of Medicine in 1980, written by Jane Porter and Dr. Herschel Jick.
I want you to picture this letter. It was 5 sentences long. 5 sentences.
Barely a paragraph.
It wasn't a peer-reviewed study. It was a brief observation to the editor. It simply noted that out of nearly 12,000 hospitalized patients who received at least one narcotic preparation, only 4 developed documented addiction.
The critical word there is hospitalized. These were patients receiving highly controlled, heavily monitored, short-term, small doses of opioids while lying in a hospital bed, mostly recovering from surgery.
Right, under constant medical supervision.
Exactly. It had absolutely nothing to do with sending a patient home with a bottle of 90 pills to take at their own discretion over 6 months.
Yet, this 5-sentence letter was cited thousands upon thousands of times in subsequent medical literature, in textbooks, and most importantly, in aggressive pharmaceutical marketing materials.
It was treated as gospel.
It was held up as definitive scientific proof that opioids were safe for long-term outpatient chronic pain. It literally became an intellectual virus.
It was a complete misapplication of data, but it perfectly fueled a growing movement in the 1990s where the medical establishment designated pain as the 5th vital sign.
Oh, I remember this.
You have temperature, pulse, respiration, and blood pressure. Suddenly, doctors were told they must measure pain just as systematically. You've seen the smiley face to crying face charts in every doctor's office.
Yeah, the pain scale.
This created immense institutional pressure. If a doctor had a patient rating their pain an 8 out of 10, the doctor was heavily pressured to satisfy that metric by reaching for the prescription pad.
Which leads to my biggest question about this era. I have to push back on the medical community a bit here. Was an entire establishment of highly educated doctors genuinely hypnotized by a 5-sentence letter out of some misplaced, naive compassion? Or was this purely a triumph of predatory corporate marketing? Like, how did so many smart people get this so wrong?
It was a lethal, synergistic combination of both. The medical community provided the fertile soil of good intentions and that fifth vital sign pressure. But it was aggressively, systematically exploited by the pharmaceutical industry.
Right, the corporate side.
Specifically, Purdue Pharma, a company owned by the Sackler family. They recognized a historically unique, multi-billion-dollar opportunity. In 1996, they launched OxyContin.
Break down what OxyContin actually is, because the name itself was part of the trick, wasn't it?
Yeah, Oxy stands for oxycodone, a powerful synthesized opioid similar to morphine. Contin stands for continuous. It was an extended-release formulation.
So it didn't hit you all at once.
Exactly. The pill was designed with a special coating that would slowly release the oxycodone over 12 hours, rather than all at once. And Purdue took this mechanism to the FDA and managed to secure a label claim that would prove to be one of the most catastrophic regulatory decisions in history.
What did the labels say?
The FDA allowed Purdue to claim that because the drug released slowly, it was believed to reduce the abuse liability and risk of addiction compared to immediate-release opioids.
And what was that FDA label claim based on? I'll tell you. A single study that lasted exactly 6 weeks. 6 weeks.
It's absurd.
Anyone who works in addiction medicine will tell you that the physiological rewiring of addiction takes months to fully cement. But Purdue didn't care. They took that FDA label, that golden seal of government approval hinting at safety, and they built a marketing juggernaut, the likes of which medicine had never seen.
They deployed over 900 sales representatives across the country. They targeted primary care physicians, family doctors who had no specialized training in addiction or complex pain management.
Ones you see for a standard checkup.
Right. They armed these reps with branded plush toys, golf balls, and highly misleading charts. They didn't outright cross the legal line to say it was 100% non-addictive, but they aggressively minimized the risks.
And they had that crazy workaround for when people did get addicted, right?
Pseudo-addiction. They coached their reps to use this concept. If a patient came in exhibiting classic signs of addiction, begging for early refills, showing withdrawal symptoms, the reps told doctors, no, that's not addiction, that's pseudo-addiction. It means their pain isn't fully controlled. The solution is to increase their dose.
It is brilliant, evil logic. The cure for the side effect of the drug is more of the drug.
Just endless escalation.
And they had unprecedented data tracking. They bought sophisticated prescription data to track exactly which doctors were prescribing the highest volumes. You'd think a responsible company would look at a rural doctor prescribing 500 pills a day and flag them to the medical board as a potential pill mill.
You would hope so.
Instead, Purdue sent more sales reps to those doctors with catered lunches to encourage them to prescribe even more.
And we know unequivocally that this wasn't accidental ignorance. Internal company documents and emails revealed during years of intense litigation showed that Purdue executives knew very early on that the drug was being widely abused.
They knew people were bypassing the coding.
They knew people were simply crushing the pills, which instantly defeated the continuous release mechanism, allowing them to snort or inject a massive 12-hour dose of oxycodone all at once.
There is an email from 2001 that just boils my blood. Richard Sackler, the president of the company, responds to the growing news reports that people are crushing his pills and dying. Does he call for a recall? Does he express horror?
No.
No. He writes an internal email stating that the company's strategy should be to hammer on the abusers in every way possible. He wanted to publicly blame the patients. He wanted to frame the people whose addictions his company's marketing had actively created as criminals and degenerates to protect his patent and his profits.
It is textbook corporate malfeasance. But it's vital to recognize that a corporation can only get away with this if the watchdogs are asleep, or worse, complicit.
They're regulators.
Exactly. This crisis points a very critical, harsh light at the FDA and introduces the concept of regulatory capture.
Define regulatory capture for us, because it's a term that gets thrown around, but it has very real, deadly consequences here.
Regulatory capture happens when a regulatory agency, created to act in the public interest, instead advances the commercial or political concerns of the special interest groups that dominate the industry it is charged with regulating.
So they essentially work for the industry they're supposed to police?
Pretty much. In the 1990s, the FDA was chronically understaffed and under immense pressure to approve drugs faster. Furthermore, the agency is partly funded by user fees paid by the very pharmaceutical companies it is supposed to be regulating.
It's like having the players on the field paying the referee's salary. And there's a revolving door.
Oh, the revolving door is the most glaring, undeniable example of this. Look at Dr. Curtis Wright. He was the FDA official who personally oversaw the medical review and the initial approval of OxyContin.
He signed off on it.
He was the one who signed off on that fateful, unproven label language about the delayed release mechanism reducing the risk of addiction. Shortly after the drug was approved, Dr. Wright left the FDA. And where did he go? He went to work for Purdue Pharma, with a first-year compensation package reportedly approaching $400,000.
While that was technically legal at the time, you don't need a law degree to see how that pattern severely corrodes the independence and integrity of regulatory judgment.
It creates an enormous conflict of interest.
If you are regulating a company that you know might offer you a vastly more lucrative job next year, how hard are you really going to push back on their label claims? And it wasn't just him. The FDA continued approving new, ever more potent opioid products throughout the 2000s, even when the epidemic was glaringly obvious. They heavily resisted implementing strict monitoring systems, largely due to intense, incredibly well-funded industry lobbying.
So as a result of all this, the manipulated science, the predatory marketing, the regulatory failures, we had a massive, unprecedented flood of pharmaceutical-grade narcotics entering the American market.
Which brings us to the most vital question. Where did all these pills actually go? Who was taking them? Because they didn't just land evenly across the country. They pooled in very specific places, which brings us to the economics of despair.
Right. To understand the geography of this crisis, we have to look at the work of two brilliant economists, Angus Deaton and Ann Case. They identified a phenomenon they termed deaths of despair.
Deaths of despair.
When we look at the initial explosion of this epidemic, the communities hit hardest weren't random. They were regions that had been completely hollowed out by deindustrialization.
We're talking about the Rust Belt, places in West Virginia, Ohio, Pennsylvania, Kentucky. For generations, these places had economies built on intense, physically demanding but well-paying industrial labor. Coal mining, steel mills, auto manufacturing.
When those industries collapsed in the 1980s and 90s or moved overseas, they didn't just take away incomes, they shattered the social identity of entire regions.
The whole fabric of the community.
The community organization, the union halls, the sense of intergenerational purpose, all of it vanished. What was left behind was a massive psychological void and a population dealing with the very real, chronic, physical pain of a lifetime of hard manual labor.
I look at it as a perverse, inverted corporate supply chain. For a century, these towns exported the coal that powered the nation and the steel that built our cities. When those exports stopped, the supply chain inverted. Instead of exporting valuable goods, these towns became captive importers.
And what were they importing?
Literal and existential numbing. They were importing a chemical escape from the economic reality that society had abandoned them.
That economic devastation created an incredibly vulnerable population, and the illicit market capitalized on it with terrifying efficiency. This is the era of the Oxy Express. Because prescribing laws were slightly tighter in some northern states, a massive pipeline developed between the Rust Belt and the state of Florida. Because at the time, Florida had essentially zero regulation on pain clinics. It was a free-for-all. Strip mall pill mills opened up by the hundreds. They were cash-only businesses.
You just walk in with cash.
You would walk in, pay a couple $100s, get a cursory 2-minute MRI review by a doctor, and walk out with a prescription for 300 OxyContin and Xanax pills. People would literally charter buses from Kentucky and West Virginia, drive down to Florida, hit half a dozen clinics in a weekend, and drive back up.
They would keep some for their own addiction and sell the rest at a massive markup back home. It created a toxic, localized cash economy that directly replaced the legitimate industrial jobs that had vanished. It was an economy built entirely on addiction. But let's look higher up the chain than the guys driving the buses. The supply chain data is where the true culpability lies, right?
We have to talk about the distributors. These are the massive Fortune 500 logistics companies, McKesson, AmerisourceBergen, and Cardinal Health. They act as the middlemen between the manufacturers like Purdue and the local pharmacies.
And they have rules they have to follow.
Under federal law, these distributors have a strict legal obligation. They are required to monitor the shipments and report any suspicious orders to the DEA. If a small pharmacy suddenly orders 1,000 times its normal volume, The distributor is supposed to freeze the shipment and alert the authorities.
Did they do that?
No, they shipped billions of pills. The state of West Virginia, which has a population of about 1.8 million people, received 780 million hydrocodone and oxycodone pills over a 5-year period.
That is insane.
That is enough to supply every resident with over 400 pills. The distributors simply ignored the blatantly suspicious orders because the profits were too astronomical to pass up.
I go back to that town I mentioned in the hook. Kermit, West Virginia, population 392, receiving 9 million pills over 2 years at a single small pharmacy. You are a massive logistics company. Your algorithms track every single bottle. You see a town of under 400 people ordering millions of narcotics and you don't pick up the phone. How does that happen without law enforcement stepping in and shutting the whole thing down?
Well, law enforcement tried. The Drug Enforcement Administration, the DEA, had agents who saw exactly what was happening. They tried to aggressively crack down on these distributors, to pull their licenses, to ship controlled substances.
And what stopped them?
When they started getting close, the pharmaceutical industry deployed its ultimate weapon, lobbying Congress.
This is one of the most enraging parts of the entire history in the source text.
It truly is. In 2016, Congress passed a law called the Ensuring Patient Access and Effective Drug Enforcement Act. It sounds like a noble, protective law. In reality, it was backed by heavy pharmaceutical lobbying, and it actively hobbled the DEA.
It handcuffed them.
It fundamentally raised the legal standard of proof required for the DEA to freeze a suspicious shipment. It made it incredibly difficult to stop the flow of pills. And the darkest irony, that legislation was crafted, in part, by a former top DEA official who had gone through the revolving door and was now working as a consultant for the pharmaceutical industry.
It's effectively a legislative handcuff on law enforcement, bought and paid for by the very industry they were trying to police. But eventually, the sheer body count became too massive to ignore. The media caught on. The public outrage grew. And the medical and regulatory establishment finally, belatedly, started to crack down.
Right, around 2010.
Purdue was forced to formulate an abuse-deterrent version of OxyContin. The pill mills in Florida finally got raided and shut down. Doctors became terrified of losing their licenses, so prescribing guidelines got much, much tighter.
Which brings us to the tragedy of unintended consequences. Policymakers and the medical community essentially pulled the emergency brake. They dramatically cut off the supply of relatively clean, pharmaceutically predictable prescription opioids.
But they did it without providing any massive, simultaneous expansion of addiction treatment for the millions of people who are already physically dependent. By doing the right thing, medically cutting off the bad pills, did our policy solution directly trigger the vastly deadlier second and third waves of this crisis?
Unquestionably. You have an entire population whose brain chemistry has been fundamentally rewired to require massive daily doses of opioids just to avoid agonizing, crippling withdrawal. When their doctor cuts them off, they don't just suddenly decide to go to rehab, especially when rehab isn't available or affordable.
They can't just tough it out.
No. To avoid the agony of withdrawal, they turn to the street. Studies showed that pushing prescription opioid users off their meds drove 4 out of 5 of them directly into the illicit market.
And who was waiting for them in the illicit market? The Mexican cartels. Specifically, organizations like the Sinaloa cartel. They are incredibly sophisticated, multi-billion-dollar logistical enterprises. They saw the American prescription supply drying up, and they instantly capitalized.
They didn't miss a beat.
They drastically ramped up poppy cultivation in Mexico and flooded the American market with cheap, potent black tar heroin.
That was the second wave. The shift from pills to heroin. It brought a massive spike in overdose deaths, infections from intravenous use, and hepatitis C. But as terrible as the heroin wave was, it was still reliant on an agricultural product. You have to grow poppies, wait for the harvest, process the opium, and deal with weather and crop eradication efforts. It's labor-intensive.
But by 2013, the cartels found a way to bypass agriculture entirely. The crisis mutated again into the third wave. And this is where the story shifts from tragic to apocalyptic. This is the era of synthetic fentanyl.
Fentanyl was originally synthesized in 1960 by Paul Janssen in Belgium. It is a spectacular medical invention when used correctly in an operating room by an anesthesiologist. It acts almost instantaneously and clears the body quickly. But the math on fentanyl is absolutely terrifying. It is 50 to 100 times stronger than morphine.
I want you to conceptualize that power. An expert once told me to visualize a penny. A lethal dose of fentanyl is about 2 milligrams. If you put 2 milligrams of fentanyl on a penny, it looks like a few tiny grains of table salt resting on Lincoln's nose. It is essentially invisible to the naked eye. But from an illicit business perspective, that potency is economically transformative, isn't it?
It changes the entire paradigm of global drug trafficking. You no longer need thousands of acres of poppy fields in the mountains of Sinaloa. You just need a small, clandestine laboratory in an apartment building.
You don't need farmers anymore.
You import cheap precursor chemicals from overseas, often from China, and a cartel chemist synthesizes pure fentanyl. A few kilograms of fentanyl, which can fit into a single backpack, can be diluted and pressed into millions of individual doses. The profit margins are astronomical. A cartel can invest a few $1,000s in chemicals and generate millions of dollars in street value.
Initially, they were just using this fentanyl to adulterate the heroin supply, to give weak heroin an extra kick. But eventually, it completely replaced heroin. And then they got even smarter. They realized that a lot of Americans were terrified of needles and the stigma of heroin, but they were perfectly comfortable swallowing a pill that looked like it came from a pharmacy.
The fake pills.
So the cartels bought pill presses. They started churning out counterfeit pills designed to look exactly like prescription OxyContin, the blue M30 pills.
To a user, these pills look identical to a legitimate pharmaceutical. But inside, it's just cheap filler and a microscopic, often entirely unmeasured speck of fentanyl. Because these clandestine labs aren't using industrial pharmaceutical mixers, the fentanyl isn't distributed evenly.
Oh, the chocolate chip cookie effect.
Right. One pill might have 0 fentanyl. The next pill from the exact same batch might have 4 milligrams, a double lethal dose. It's playing Russian roulette with every single dose.
And now, it's not just in the counterfeit opioid pills. Fentanyl has spread into the cocaine and methamphetamine supplies across the country. I want to stop here and make sure we really understand the physical mechanics of this. For you, the listener, trying to grasp the sudden lethality of this, what does this actually do to the human body? How exactly does a fentanyl overdose work?
It all comes down to a small, primitive area at the base of your skull called the brainstem. The brainstem controls the automatic functions you don't have to think about, primarily your respiratory drive.
Breathing.
Right. It monitors the carbon dioxide levels in your blood and sends the signal to your lungs to inhale. When opioid receptors in the brainstem are overstimulated by drugs, this drive is suppressed. The brain essentially forgets to tell the lungs to breathe.
So the person just stops breathing.
Yes. Breathing slows down, becomes shallow, and eventually stops entirely. This leads to hypoxia, a severe lack of oxygen to the brain. Without oxygen, brain cells begin to die within minutes. If the respiratory drive isn't restarted, the person dies.
And fentanyl amplifies this danger exponentially compared to heroin, right?
Absolutely. Because it is so highly lipophilic, meaning it crosses the blood-brain barrier incredibly fast, the onset of respiratory depression happens in a fraction of the time. With heroin, an overdose might take 20 or 30 minutes to become fatal. There is a window for a friend to notice, to call an ambulance, to intervene.
And with fentanyl,
the person can become unconscious and stop breathing within seconds or minutes. That window for intervention vanishes.
and crucially, because it is now contaminating non-opioid drugs like cocaine or party drugs, it is killing a completely different demographic. It is killing users who have absolutely zero biological tolerance to opioids. A college kid takes a line of what they think is cocaine at a party.
Yeah.
Their respiratory system has never encountered an opioid before. The fentanyl hits their brainstem and their breathing just shuts down instantly.
That is why we are seeing so many mass overdose events where multiple people at the same location collapse simultaneously.
I look at this underground chemistry, and I can't help but compare it to a digital arms race. It's like mutating computer malware. Every single time the government regulators or medical professionals block one chemical pathway or figure out an intervention, the illicit market mutates the code. It evolves into something cheaper, stronger, and more resistant to our medical antivirus. Which brings us to the terrifying post-fentanyl complications, xylazine and medetomidine.
This is where the landscape becomes almost unspeakably horrific. The cartels didn't stop with fentanyl. In the last few years, they began adulterating the fentanyl supply with xylazine. On the street, it's known as tranq. Xylazine is a heavy veterinary sedative used for large animals like horses and cattle.
Why on earth would they add a horse tranquilizer to fentanyl?
Because the fentanyl high, while incredibly intense, is very short-lived. Users were having to inject themselves every 2 hours just to avoid withdrawal, which is exhausting and expensive. By cutting the fentanyl with xylazine, the cartels found they could artificially extend the duration of the high, mimicking the longer legs of traditional heroin.
But the side effects on the human body are out of a horror movie.
They are. Xylazine causes severe vasoconstriction. It restricts blood flow to the extremities. As a result, chronic users develop massive, necrotic skin ulcerations, deep, rotting wounds that erupt not just at the injection site, but all over the body. If untreated, the tissue dies, leading to bone infections and ultimately amputations.
And the most dangerous part from a survival standpoint, xylazine is fundamentally not an opioid.
Correct. It works on alpha-2 adrenergic receptors in the brain, completely bypassing the opioid system.
Meaning that our miracle antivirus software doesn't work. I'm talking about naloxone or Narcan. That is the nasal spray that can literally bring someone back from the dead during an opioid overdose by knocking the opioids off the receptors.
Exactly. If someone overdoses on a mixture of fentanyl and xylazine, you administer Narcan. The Narcan will successfully reverse the fentanyl component, restoring the person's respiratory drive so they don't asphyxiate. But because Narcan does nothing to alpha-2 receptors, the person remains dangerously, unrousably sedated from the xylazine. They might be breathing, but they are completely unresponsive for hours.
It complicates the response for paramedics immensely. And before the public health apparatus could even begin to formulate a national strategy for xylazine, the market mutated again, like clockwork. By 2024 and 2025, we saw a massive surge of yet another, even stronger animal sedative hitting the East Coast and the Midwest. It's called medetomidine, or dextamiter.
The data coming out of frontline drug checking programs in Philadelphia was staggering. They showed medetomidine taking over the fentanyl supply in mere months, actively displacing the xylazine. The cartels are constantly beta testing new chemical cocktails on the American public to see what maximizes dependency and profits.
And this new chemical brought entirely new horrors, didn't it?
Yes. Medetomidine is significantly more potent than xylazine. When chronic users try to stop, or when they end up in an emergency room, hospitals began documenting a severe, chaotic cardiovascular withdrawal syndrome.
What does that look like?
We are talking about extreme, life-threatening blood pressure spikes and heart rate elevations that standard hospital treatments simply couldn't touch. Clinicians even began noting profound hallucinations and psychosis in patients withdrawing from medetomidine, which wasn't typically seen with xylazine or standard opioids.
It's an absolute nightmare for emergency room doctors. Once again, the federal health authorities find themselves years behind the frontline harm reduction workers, desperately trying to catch up to a completely mutated synthetic drug supply.
To truly understand why people can't just walk away from this, why they continue to seek out these mutating, flesh-rotting, lethal chemicals, despite knowing the immense risks we have to look at the physical architecture of the human brain, we have to discuss the neuroscience of addiction.
Right. Because the prevailing societal narrative for decades has been that addiction is a moral failing, a weakness of character, a lack of willpower. If you just tried harder, if you loved your family enough, you would stop. But what is actually happening in the brain's survival hardware? Break down the mechanics for us.
The brain has a built-in reward system centered on something called the mesolimbic dopamine pathway. From an evolutionary standpoint, this system is perfectly designed to ensure our survival.
It's what keeps us alive.
When you engage in behaviors necessary for keeping your genes alive, eating a calorie-rich meal, drinking water when thirsty, or social and romantic bonding, your brain releases a moderate natural surge of dopamine. Dopamine is a neurotransmitter that essentially tells the brain, that was good, remember how to do that, and prioritize doing it again.
It's the biological sticky note that says this equals survival.
Exactly. Now, opioids completely hijack and override this delicate system. When an opioid binds to the mu-opioid receptors in the brain, it unleashes a surge of dopamine that is vastly larger, more rapid, and more intense than any natural reward achievable in normal human life. It is an overwhelming chemical euphoria. And the brain's architecture responds to this massive flood of chemicals by physically rewiring itself.
Walk us through that rewiring. I've heard the term downregulation. What does that actually look like?
Think of the receptors in your brain like microphones, and the dopamine as the sound. If someone suddenly blasts music through a massive concert speaker directly into those microphones, the system gets overwhelmed. To protect itself from blowing a fuse, the brain essentially turns the sensitivity of the microphones down. It decreases the number of available mu-opioid receptors and makes the remaining ones less sensitive. This is downregulation.
So the brain is actively building a tolerance. You need more and more of the drug just to get the same effect because half your microphones are turned off.
Yes. But here's the critical, tragic part. When the drug is removed, when the concert speakers are turned off, those down-regulated microphones are still deafened. Now, the normal, natural amounts of dopamine produced by eating or hugging your child barely register. The person feels profoundly depressed, lethargic, and incapable of experiencing normal joy. Anhedonia.
And the withdrawal isn't just a lack of joy, it's physical agony.
Precisely. Because the brain's anti-stress systems, which were working overtime to balance the massive influx of opioids, are suddenly left unopposed. It produces a state of hyperarousal, intense physical pain, bone aches, vomiting, diarrhea, panic attacks, and an all-consuming biological craving.
The science makes it undeniably clear. Severe addiction is a fundamental neurobiological reconfiguration. The person's brain is literally dedicating all its computational power and survival instincts to drug seeking because the altered brain truly believes that acquiring the drug is as vital to survival as oxygen. So I have to push back on society here. If neuroscience proves definitively that the brain physically changes, why is there such immense ingrained cultural resistance to treating addiction the exact same way we treat other chronic physiological diseases? If you have diabetes, your pancreas doesn't produce insulin correctly, so a doctor prescribes synthetic insulin. Why can't we do that for the brain?
That is the great, frustrating paradox of the treatment landscape in America. We do have the medical equivalent of insulin for opioid addiction. It is called medication-assisted treatment, or MAT, sometimes referred to as medications for opioid use disorder. The clinical empirical evidence overwhelmingly supports using medications like methadone and buprenorphine.
How do they work?
They are long-acting opioids. They bind those same opioid receptors, but they do it slowly and steadily. They don't produce the massive euphoric spike of fentanyl, but they satisfy the receptor. They stabilize the brain, completely eliminate the agony of withdrawal, block the intense cravings, and allow the person to function normally, hold a job, and repair their life. Extensive studies show that being on MAT reduces the risk of a fatal overdose by up to 50%. It is the gold standard of care.
Yet for decades, access to this life-saving medication was severely, punitively restricted by the very government agencies supposed to be fighting the crisis.
Yep.
Take methadone. You couldn't just get a prescription from your doctor and pick it up at the pharmacy like a normal medication. You were legally required to travel to a specialized, highly regulated methadone clinic every single morning, stand in line, and take your dose under observation.
Which is incredibly disruptive if you are trying to maintain a normal job or care for children. And then there was buprenorphine, often known by the brand name Suboxone. The government created a system where a doctor had to jump through massive bureaucratic hoops, taking special training courses to get a federal waiver, the Data 2000 waiver. And even with the waiver, the government strictly capped how many patients a single doctor could treat with buprenorphine.
It's historical absurdity. We allowed doctors with zero specialized training to prescribe unlimited amounts of OxyContin to create the addiction, but we placed federal caps on doctors trying to prescribe the cure. That Data 2000 waiver was finally repealed in 2022, but the damage of 2 decades of restricted access was already done. We lost hundreds of thousands of people who couldn't access the medication they needed. But the cultural friction isn't just coming from federal regulators. It is deeply embedded within the recovery community itself, isn't it?
It is a profound philosophical divide. The traditional American model for addiction treatment is heavily based on the 12-step philosophy and abstinence-only residential rehabs. For decades, many within this community viewed MAT not as medical treatment, but as simply trading one addiction for another. They believed that true recovery required absolute abstinence from any opioid-based substance.
Even if that substance was prescribed by a doctor and legally keeping you alive?
Exactly. Many residential programs flat out refused to admit patients who are on buprenorphine or methadone. They forced highly vulnerable people to choose between the only medically proven treatment for their altered neurobiology and access to a bed, therapy, and residential care. It was a deadly ultimatum.
This clash between clinical medical reality and deeply held cultural belief perfectly frames the contested ground of harm reduction in politics, which is a massive part of understanding where we are today. We need to lay this out objectively for you, the listener, looking at both sides of what has become a very heated, polarized debate. What exactly does harm reduction entail in practice, and what is the core philosophy dividing people?
The core philosophy of harm reduction is radical pragmatism. It prioritizes immediate physical survival above all else. The central tenet is acknowledging that Regardless of laws or moral judgments, some people are going to use drugs today. The goal of harm reduction is to ensure they don't die or contract a fatal disease while doing so, keeping them alive until they are ready and able to engage in treatment.
So practically, this means things like needle exchange programs to prevent the transmission of HIV and hepatitis C. It means distributing fentanyl test strips so users can check their drugs before they take them. It means massive, ubiquitous, over-the-counter access to Narcan.
Yes. And at the most controversial edge of the spectrum, it includes supervised consumption sites. These are legally sanctioned facilities where individuals can bring their own illicit drugs and use them under the direct supervision of trained medical staff equipped with oxygen and Narcan.
I know this concept makes a lot of people instantly uncomfortable, but what does the data actually say about these sites?
The clinical data from across the globe is incredibly strong. Facilities in Canada, Europe, and Australia have operated for years. The data shows that supervised sites globally have safely reversed thousands upon thousands of overdoses. To date, there has never been a recorded fatal overdose inside a sanctioned, supervised consumption site. They also serve as a crucial entry point, connecting deeply marginalized people with medical care and eventual addiction treatment. Advocates often point to Portugal's 2001 decriminalization model. Portugal decriminalized the personal possession of all drugs and shifted the massive resources previously spent on policing into funding a robust public health and treatment infrastructure. It resulted in a massive, sustained drop in overdose deaths and new HIV infections.
That is the medical argument.
It is
and compelling, but I also want to voice the very real concerns of the enforcement and abstinence perspective. Because how does a society actually balance the undeniable medical efficacy of saving a life inside a clinic today with the surrounding community's right to public safety, sanitation, and order?
It is the defining civic tension of this crisis. The opposing view, often rooted in community impact, argues that removing the legal consequences and friction from drug use fundamentally enables and normalizes the behavior. Critics point out that the residents and small business owners in the immediate vicinity of these open-air drug markets or harm reduction sites bear very real, very heavy costs.
Right. We are talking about discarded needles in public parks where children play. We're talking about spikes in property crime, retail theft to support habits, and a general degradation of public space and civic order. You can't just tell a small business owner who has to clean up human waste and needles off their doorstep every morning that they just need to be more medically compassionate. Their anger and their reality are completely valid.
Furthermore, critics of the pure harm reduction model argue that a system focused entirely on keeping people alive in their addiction can quietly, perhaps unintentionally, abandon the ultimate goal of full recovery. They argue it leaves deeply traumatized people in a state of permanent, state-sponsored substitute dependency rather than pushing them toward a life free of chemical reliance.
And we've seen this tension play out in real-time politics. Look at Oregon. In 2020, voters passed Measure 110, which essentially decriminalized the personal possession of hard drugs, attempting to mimic the Portugal model. But by 2024, the state legislature repealed key parts of it, recriminalizing possession. Why? Because the public backlash against the visible public disorder, the open-air drug use, and the lack of mandated treatment was overwhelming.
We also see the shifting at the highest federal levels. Look at the policy shifts in 2025 under the Department of Health and Human Services, led by Secretary Robert F. Kennedy, Jr. His administration actively pushed back against the medication-first harm reduction paradigm. He promoted policies favoring civil commitment, legally mandating individuals into treatment, and advocated for abstain-based wellness farms rather than expanding access to buprenorphine.
It's a profound, incredibly difficult tension between individual medical intervention and macro-community impact. Neither side is operating out of malice. They are just prioritizing different definitions of safety and recovery. But let's zoom out even further to the macro level, looking at justice, inequality, and the broader geopolitical response. I want to go back to something we touched on earlier regarding the war on drugs. When you look at how the legal system responded to this crisis in the 2000s compared to the 1980s, the contrast is blistering.
The racial double standard is stark, and it is documented fact. When crack cocaine devastated urban, predominantly black communities in the 1980s and 90s, the governmental response was massively, overwhelmingly punitive, We saw the implementation of harsh mandatory minimum sentences. We saw the militarization of local police forces, mass incarceration on an unprecedented scale, and almost zero framing of the issue as a public health or medical crisis. The users were labeled super
But
predators.
when the opioid epidemic initially exploded in the early 2000s, hitting predominantly white, rural, and suburban communities, the political rhetoric shifted almost overnight. Suddenly, it was a tragedy. It was a public health emergency. We needed compassion and treatment, not prison cells. The compassion of the American legal and medical system was, quite clearly, ethnically conditional.
And even if you look strictly within the legal realm of the opioid crisis itself, the disparity in justice is glaring. Black Americans continue to face vastly disproportionate arrest and incarceration rates for street-level drug offenses, even during the era of opioid compassion. Meanwhile, the pharmaceutical executives, the architects who engineered the crisis from their boardrooms, who lied to regulators and hid the data, face civil fines, not criminal consequences.
That brings us squarely to the 2025 Purdue Pharma bankruptcy settlement.
Hmm.
This is the ultimate example. The Sackler family agreed to a settlement of up to $7.4 billion. The company itself dissolves. The Sacklers are permanently banned from the opioid business, and their name is stripped from museums and universities around the world. But here is the kicker. Zero criminal prosecutions for the executives.
Huh.
Nobody goes to a prison cell. I liken it to getting a speeding ticket for committing a massive bank robbery. If you steal $1 billion and the fine is $100 million, that's not a penalty. That's just a business tax on a highly profitable venture.
From a purely legal standpoint, prosecutors argue that proving individual criminal intent beyond a reasonable doubt within a complex corporate bureaucracy is incredibly difficult. Corporations diffuse responsibility perfectly. But sociologically, contrasting that insulated financial penalty for a billionaire executive with a street-level user doing a decade in federal prison for selling a handful of pills, it is a bitter pill for society to swallow. It corrodes trust in the fundamental fairness of the justice system.
The macro scale of this crisis eventually expanded beyond domestic courts. It became a massive geopolitical issue. We started treating fentanyl not just as a drug problem, but as a national security threat.
Because of the supply chain, the cartels in Mexico are synthesizing the fentanyl, but they are relying heavily on massive shipments of precursor chemicals originating from chemical companies in China. This led to severe diplomatic tensions. In 2025 and 2026, President Trump threatened sweeping major economic tariffs against China, Mexico, and even Canada, demanding they take aggressive military and regulatory action against cartel trafficking and chemical exports.
Did it work? Yeah. Did the geopolitics actually stem the tide?
It's complex. Under intense diplomatic pressure, China did eventually agree to tighten domestic controls and shut down some of the companies exporting specific precursor chemicals. Mexico ramped up military raids on clandestine labs. However, politically, the Supreme Court ultimately revoked the emergency executive powers used to justify those broad tariffs.
But this is where analyzing the data gets fascinating, especially regarding that massive drop in overdose deaths we talked about at the very beginning of the show, the drop from 110,000 down to under 70,000. Politicians love to take credit for drops like that. Was it the tariffs and the border crackdowns that caused the numbers to fall?
The epidemiological data suggests otherwise. The decline in overdose deaths was actually already underway before those major tariff threats and border crackdowns fully materialized. Public health experts attributed the decline to a complex, compounding mix of domestic interventions. First, the massive ubiquitous expansion of over-the-counter naloxone in 2023. Narcan is finally everywhere in schools, libraries, and carried by citizens. Second, the belated expansion of MAT after the prescribing restrictions were lifted. And third, the influx of billions of dollars in settlement funds from the pharmaceutical companies finally hitting local counties, allowing them to build out actual treatment infrastructure.
So a combination of finally deploying the medical antivirus and building out the treatment network. But there is also a much darker, incredibly sobering hypothesis that researchers are looking at to explain the drop in deaths. The concept of demographic exhaustion. Explain what that means in this context.
It is a grim concept from epidemiology. Some researchers suggest that a substantial share of this recent decline is simply because the epidemic has literally run out of highly susceptible people to kill.
I want you to pause and really absorb what that means.
After a decade and a half of fentanyl's unrelenting, ruthless lethality, the most vulnerable, high-risk populations, the chronic intravenous users, the deeply unhoused, the severely mentally ill self-medicating with street drugs have already been massively reduced. They've been reduced by death, by long-term incarceration, or, for the survivors, by finally achieving long-term recovery. If this hypothesis holds true, The sharp decline in deaths isn't entirely a triumphant victory of policy or policing. It is simply the grim mathematical arithmetic of attrition. The fire is burning out because it consumed all the readily available fuel.
Which leaves us with a truly profound and challenging final thought for you to mull over as we conclude today. If a significant part of this recent decline in overdose deaths is indeed due to demographic exhaustion, if the fire is only dying down because it ran out of fuel, what does that say about the structural integrity of our society's safety nets?
It is the most essential question we can ask.
For decades, we have spent billions of dollars playing a frantic, militarized game of whack-a-mole with a chemical supply. We cracked down on prescription pills, so the market mutated to heroin. We cracked down on heroin, and it mutated to fentanyl. We target fentanyl, and we get xylazine and medetomidine. The supply will always find a way. But we must ponder what happens when we finally decide as a culture to address the demand for relief. What happens when we address the economic hollowing out of our working class, the systemic untreated trauma, the profound isolation and despair that makes a chemical escape so fatally attractive in the first place? Until we collectively address the toxic soil that this crisis grew in, the root remains waiting for the next rain.
It requires a fundamental willingness to confront the baseline assumptions of our punitive drug policies, our profit-driven healthcare system, and our economy.
Before we go, we want to make absolutely sure you know exactly where all of this incredible, deeply researched insight came from today. This entire deep dive, the history, the neuroscience, the geopolitical analysis, was derived from the second book of the monumental 30-volume series, To Preserve, Protect, and Defend the Soul of America. Specifically, we've been unpacking the text of Volume 2, Fentanyl Nation, Inside America's Opioid Catastrophe, authored by Sue B. Howell.
It is an incredibly remarkable, essential piece of work. It manages to pull together history, complex neuroscience, legal theory, and human sociology to clearly explain one of the most defining and devastating crises of our modern time.
And the best part is, Volume 2, Fentanyl Nation, Inside America's Opioid Catastrophe by Sue B. Howell, part of the To Preserve, Protect, and Defend the Soul of America series, is now available in all Amazon bookstores across the world. We enthusiastically encourage you to go check out the book for yourself. There's so much more granular detail, personal history, and deep data in those pages that we couldn't even begin to cover today.
We would also love to hear your thoughts on everything we discussed. Please leave comments and feedback on the show, and let us know your perspective on these complex, deeply human issues.
Thank you so much for joining us for this extensive deep dive. Stay curious, stay informed, and we'll talk to you next time.